Perfect. Okay. So first of all, thank you very much for your kind invitation. I'm going to talk about the new ILA classification of seizures and epilepsies in the neonatal period. These are my disclosures, and I would also like to ask you not to make any videos or photos of the babies I'm going to show over the next hour or so. I've got permission to use those videos for teaching, but not to distribute. Thank you. This is the overview. So I'm going to talk a bit about what are the challenges in diagnosing neonatal seizures, the definition of neonatal seizures, and then I present the new classification of seizures and the new classification of epilepsies with onset in the neonatal period. So how diagnosing neonatal seizures? Seizures are more common in the neonatal period than at any other time in life. But in contrast to seizures in older children and adults, they're mostly acute symptomatic or acute provoked. So they're not, most of them are not the onset of an epilepsy syndrome. The most common cause in term babies is hypoxic ischemic encephalopathy. That's also overall the most common cause. Maybe 40 to 50% of all babies with seizures in the neonatal period have seizures due to hypoxic ischemic encephalopathy. In preterm babies, it's intraventricular hemorrhage. Other etiologies like infarct, infections, acute metabolic or inborn errors of metabolism, genetic causes, and brain malformation can be seen at any age. The big question is always, how do you diagnose neonatal seizures? This is not so much a question in older children and adults, where the diagnosis of seizures and epilepsy is a clinical one. So can we diagnose seizures clinically in neonates too? So first of all, for you, how do you diagnose them? Do you use EEG, AEG, clinical only, or just never diagnose them? And to illustrate this problem, I'm going to show you here a video. So here you can see a baby in the ambulance, and the emergency doctor is giving this baby midazolam and oxygen. And you can see how the jerking continues despite treatment. This baby has already had phenobarbital, phenytoin, and yet midazolam as well. And nothing really helps. The baby was then transferred to our hospital, and this is the EEG. And you can see that with these arrows show you the when the baby was jerking, and there's really nothing in the EEG. So really, these events were not seizures. And sometimes it can be very difficult on a clinical basis, even for doctors who are very experienced. And this has been elegantly shown by Geraldine Boylan and her group in Ireland, in Cork. This is a study where they gave healthcare professionals, mostly doctors, but also nurses, all specialists in neonatal seizures, 20 video clips, and they asked them to identify those ones with seizures or non-seizures. So 9 were not seizures, 11 were seizures, and all they had to do is say, yes, it's a seizure, or no, it's not a seizure. And basically what this study showed, that they identified seizures correctly in 5 out of 10 events. This is like tossing a coin. So even specialists cannot diagnose seizures just on a clinical basis. And that is because non-seizure behavior in healthy and in sick babies can look like seizures. They have very similar semiology. The other problem is that a high proportion of seizures in the neonatal period is electrographic only. This is another study in Cork where they recorded seizures with EEG, but hid the EEG from the clinicians. And then, so it was a prospective study seeing how many of these seizures were correctly identified by clinicians in the clinical environment. And basically, what they found was that most of the seizures they diagnosed with EEG were not recognized by the medical staff, either because they were EEG seizures only, or they had a clinical correlate, but they were still not recognized by the staff because these babies were critically ill on ITU. It's a busy environment. So basically the reasons why there's so many electrographic only seizures is because those babies are critically ill. Many are on muscle relaxation, they are on sedation. And then there is the phenomena of uncoupling. So uncoupling means that if you have electroclinical seizures, they can become subclinical or electrographic only, and that's called uncoupling. There's also electroclinical dissociation when they become clinical only, but this is very rare and only seen if you do have also electroclinical seizures. Uncoupling is far more a problem because this makes monitoring of treatment success very difficult. So I'm going to show you an example here. So if you look at this baby, here's the head, and here's the EEG, it's an old recording. And if you look at the baby in an incubator, you can see the clonic movements of the shoulder. And this correlates, sorry, and here again, this correlates with, so when it starts with the EEG change in the EEG, the changes in the EEG, so an ictal change in the EEG. And then the baby was treated with phenobarbital, and the clinicians thought this baby responded well and became seizure-free. But the baby was still on EEG monitoring, and what you can see is that in the same region, you can see that these seizures have continued to occur, become electrographic only. So this is uncoupling. And this means that that you need EEG both for the diagnosis of seizures, but also for the monitoring of treatment success. So EEG is the gold standard in the diagnosis. Ideally, you want to do more than just EEG. Ideally, we're looking at polygraphy, so 10 to 21 electrodes. In neonates, usually it's 10 to 12 electrodes, ECG, respiration, EMG, and if you can, a display of AEG, which is extremely helpful, plus video. The duration should be 60 minutes, so you include wakefulness and sleep. And if a baby is at high risk or has seizures, it is recommended to do EEG monitoring for 24 hours, 72 hours if babies are on cooling. What are neonatal seizures? So how do we define seizures in the neonatal period? Well, in the International League Against Epilepsy has a definition for seizures in general, and that is a seizure is a transient occurrence of signs or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. And you can see this definition itself does not include electrographic seizures. It requires signs or symptoms. which means that this definition does not include around 50 to 60% of neonatal seizures. The American Clinical Neurophysiology Society, ACNS, has then defined electrographic seizures in the neonates as a paroxysmal abnormal sustained change in the EEG, which obviously makes sense. It's a repetitive evolving pattern with a minimum of 2 microvolts peak to peak and a duration of at least 10 seconds. And this definition has been adopted by most centers and organizations, including the International League Against Epilepsy. What do you do if you have an event which is less than 10 seconds? So here's an example. You can see here discharges which show an evolution. There's the frequency, the reduction of frequency, and a change in morphology. So in theory, this would fit the criteria for a seizure, but it's less than 10 seconds. So this is what we call a BIRD, or brief interictal rhythmic discharge. These are discharges with a recruitment, rhythmic discharges with a recruitment of less than 10 seconds. And they are considered a pattern of uncertain significance. They do occur in premature and sick term neonates and are associated with seizures in the same or subsequent EEG, and also associated with poor outcome. They are described in adults as well, also with associated with seizures. And at the moment, it's not quite clear whether they should be called seizures. Some have suggested they are mini seizures, because if you see the same event with a clinical association, then you would call it a seizure, but without, you don't call it a seizure. Or if you have a very similar event, like here in this EEG underneath, which looks very similar, but is longer than 10 seconds, then you call it a seizure. On the other hand, the 10-second rule is a definition which does make sense in a clinical environment and reduces the risk of over-treatment of rhythmic events that might not be seizures. So at the moment, we have the 10-second rule, and anything which is shorter than 10 seconds is not a seizure. If it's more than 10 seconds, then we would call it a seizure, which doesn't mean that any event that is more than 10 seconds should be treated. It is more important that we look at the seizure burden. And if you have a seizure burden of more than 1 minute per hour, then treatment is definitely recommended. Definition of neonatal status. The International League Against Epilepsy has recently redefined status for older children and adults. In theory, this definition, this was published by Eugen Trinker in 2015. And in theory, this also includes neonates, but it's very clear that we do not know the criteria how to use this definition for neonates. So at the end of the day, this definition does not include neonates. Again, the American Clinical Neurophysiology Society has defined status as present when the sum duration of electrographic seizures comprise more than 50% of a 1-hour EEG epoch. So if you have more than 50% of seizure activity in a given EEG, then we're talking about neonatal status. Okay. Classification of neonatal seizures. So if we have neonatal seizures, what do we call them? And to be honest, most neonatologists just call them neonatal seizures. They do not classify them. They don't use any classification we use in older patients and in adults. And this is because many,
thank you.
There is no generally accepted classification. The ILAE, as you all know, has published a number of classifications over the years. Here you see the most important ones, and none of these include neonatal seizures. It's always very clearly says neonatal seizures are not included in this classification. In response, the neonatologist Volpe in Boston has created a classification, but this is a purely clinical classification. It does not include EEG, and therefore misses out on 50% of all neonatal seizures. Plus, it includes what Volpe calls subtle seizures. And many of these subtle seizures don't have an EEG correlate, and strictly speaking, are not seizures. So any kind of jerkiness, any kind of eye movements are called subtle seizures, even though they are not if they don't have an EEG correlate. And he does recognizes this, but still, as long as you call something a seizure, people start treating it. So this is the biggest problem, is the subtle seizures without EEG correlate. Also generalized tonic seizures don't have an EEG correlate and are therefore not seizures. So this classification includes events that are not seizures and misses out on events, subclinical seizures that are seizures. Eli Mizrahi has, in response to the Volpe classification, added electrographic seizures and tried to bring the neonatal seizure classification more in line with the International League Against Epilepsy. But his classification, which he published in 1987, is rather complex and also still contains seizures that have no relationship to EEG discharges, and really hasn't ever made it into the neonatal units. The ILAE has recognized this issue and then created a task force. And our job was really to adapt the newest International League Against Epilepsy seizure classification for neonates. And so the position papers by Fischer and Scheffer is what we used to, and we tried to adapt this using the same principles and the same terminology which are used in those two classifications, and adapt them for the use in the neonatal intensive care unit. So the first thing we did, we limited to focal seizures because neonates, it's assumed that all seizures in the neonatal period are of focal onset. And then we also said we would classify according to the predominant manifestation rather than to the first manifestation. And obviously, we wanted to emphasize the need for EEG and electrographic seizures. So this is the Fischer classification. This is where we started. So as I said, we concentrated on focal onset, so no in neonates, no generalized onset, and no unknown onset because it's all focal onset. In neonates, what you don't have is bilateral tonic-clonic. So there are no bilateral tonic-clonic seizures in the neonatal period. And the other problem is that many seizures may occur, but we cannot diagnose them because babies obviously are nonverbal, they cannot speak, they cannot respond. So we don't know whether they are aware or have impaired awareness. And we cannot test for cognitive, emotional, or sensory seizures. And atonic seizures are also impossible to diagnose or difficult to diagnose because babies are naturally hypotone, they have no head control, they can't sit, they can't stand. So to diagnose atonic seizures, you would need to use invasive methods like invasive EMG, which we do not do. So also atonic seizures don't really occur in neonates. So we have a much smaller number of seizures we need to take into account. But as I said, we wanted to emphasize the EEG. So we start with a baby which is either critically ill with a high risk of seizures. So any baby with hypoxic ischemic encephalopathy, stroke, hemorrhage, inborn error of metabolism, any babies where we know there is a high risk of seizures, or a baby with a clinical suspicion of seizures. So where we have events, clinical events, which we think may be seizures. And then we use EEG or AEG to confirm whether this event is a seizure or not. Non-seizure events are taken out of the classification straight away. So we only consider events with an EEG correlate as a seizure. And then if we have a seizure, then this is classified with clinical signs or without, electrographic only. And seizures with clinical signs are then classified similar to the Fischer classification into motor, non-motor, and unclassified. And then we also added one extra seizure type, the sequential seizure. And I come back to that. So motor is automatisms, clonic, epileptic spasms, myoclonic, tonic, and non-motor is autonomic seizures and behavioral arrest. And I'm going to show you a few examples now. So here is a baby. First the video. So you can see he's relatively well. And if you look at his hand, he's moving around. But if you look carefully, you see rhythmic, repetitive jerking, which is regular. But you have to look very carefully. And this is a clonic seizure. So a clonic seizure consists of involuntary contractions of muscle and muscle groups, which are regular, repetitive, typically at 2 to 3 per second and prolonged. In neonates, they can be at a lower frequency. And this seizure type is relatively easy to diagnose. This was also one of the results of the study I showed you earlier by Malone, where they showed video clips to neonatologists. They also found that clonic seizures are relatively easy to diagnose. These were the ones which were best identified clinically. Focal clonic seizures, if they are unilateral, are very suspicious of stroke. This baby here had a stroke. It's a baby with a cardiac disorder. He has a crisscross heart. And after the operation, after his first cardiac operation, had a stroke and then developed these focal clonic seizures. Obviously, if they are multifocal, so on one side and the other, then it's very likely that they are different etiology, for example, hypoxic ischemic encephalopathy or infections. But if you have a unilateral clonic seizure in a newborn baby, I would say this is a stroke until proven otherwise. Next, tonic seizures. So here is a 2-week-old baby. And you can see an asymmetric tonic posturing of both arms. I'll show this again. It is both arms, but it's clearly asymmetric, starting with the right arm, and a sustained increase of muscle contractions. So a tonic seizure is sustained increase in muscle contractions, which lasts seconds to minutes, is longer than 2 seconds, so longer than spasms. I come back to that. In theory, it can last up to minutes. In neonates, it usually lasts 10 to 30 seconds. But what is important is these seizures, tonic seizures in neonates, are focal or asymmetric, like in this baby. If you have generalized tonic events, then these are not seizures. If they are clearly symmetrical and bilateral tonic posturing, those events are usually or are not seizures. They occur in babies with severe brain damage and are typically associate, it's what Mizrahi called a brainstem release phenomena. So they can be evoked with stimulation, and if you hold the baby, they will stop. Whereas if you have a seizure, those you cannot interrupt when holding the baby. Tonic seizure are typical for early infantile, developmental, and epileptic encephalopathy, and can also be seen in other genetic neonatal epilepsies. Okay, next one, myoclonic seizures. So here you see a baby in an incubator during photic therapy, and you can see those irregular, jerky movements here with an EEG correlate. Typically, these occur single or multiple with variable topography. So myoclonic seizures are involuntary contractions of muscles. They are sudden and brief, under 100 milliseconds by definition. And here it's really important that you have an EMG channel, because without an EMG channel, you cannot really say how long this event is. And so what we do is we do routinely in any baby, we also add 2 deltoid EMG channels, surface electrodes, to look at the EMG, so we can measure and differentiate spasms, myoclonic, hold on, where are we? Myoclonic seizures and tonic seizures. Clinically, it's very difficult or impossible to differentiate myoclonic seizures from non-epileptic myoclonus. So if you remember the baby I showed you at the very beginning, the baby in the ambulance, this was non-epileptic myoclonus. It was neonatal sleep myoclonus, whereas this baby had myoclonic seizures. This is a preterm baby with myoclonic seizures. Myoclonics, so you definitely need EEG to confirm whether jerky event is seizure related or not. Myoclonic seizures are typical for early infantile, developmental, and epileptic encephalopathy if they are due to inborn errors of metabolisms. And they are also a typical seizure type in preterms. Next are automatisms. So here you have a baby, again in an incubator, and if you look at his mouth, you can see he's mouthing this, chewing, a bit of hypersalivation, sort of sucking movements. So by definition, it's a more or less coordinated, repetitive motor activity, which resembles a voluntary movement or action, in same as in older children and adults. In neonates, these are mostly oral, but they can also have manual automatisms, but it's quite rare. Again, this looks like normal or abnormal behavior in neonates, and you do need EEG confirmation. There is no way that you can differentiate this behavior just by clinical diagnosis. It's very rare that automatisms are an isolated manifestation of seizures. It can happen, but much more often you find automatisms as a part of a sequential seizure, particularly in self-limited neonatal seizures. Next one is spasms. So here you see a baby with spasms. It's a sudden flexion, extension, or mixed extension flexion of proximal and truncal muscles. They are more sustained than myoclonus, so longer than 100 milliseconds, but shorter than tonic seizures, so shorter than 2 seconds. They're relatively rare in neonates, but if you see them, then they're typically for pyridox-independent seizures or other inborn error of metabolism, sometimes also in genetic epilepsies. So this baby has pyridox-independent seizures. So finally, sometimes, as I said earlier, the classification is according to the predominant manifestation. And in most of the seizures I've shown you, you have one predominant manifestation, and it's quite straightforward to say what it is. Sometimes you have babies which have much more complex seizures. And I'm showing you this one. So this starts in the middle of a seizure, and you see there's a tonic phase, and then so then there's a clonic phase and blinking, and also oral automatisms. If you look at the mouth, you can see quite marked oral automatisms, and then clonic movements, which are on both sides, but alternating. And this is what we call a sequential seizure. So a variety of clinical signs during a given seizure. Typically, there is a sequence of heterogeneous components, and very often they have a tonic phase. So this baby, typically they start with a tonic phase. And this seizure type is typical for channelopathies. So we see them in babies with self-limited neonatal epilepsies, but also in Casein Q2 encephalopathy. And this baby had a Casein Q2 encephalopathy. And the reason why it is so important to give them a special name and make clinicians aware that this is different to other seizure types is because these babies respond to carbamazepine. Carbamazepine we usually don't use in the neonatal period, but in babies with channelopathy, newborns with channelopathy, particularly with Casein Q2 or STN2A, these babies respond very promptly and very well to carbamazepine. And so this is why we wanted to highlight these syndromes and giving this typical seizure type a special name with a sequential seizure, because it doesn't really fit, doesn't fit in any of the other seizure types. So then we also in the task force validated the seizure classification. We looked at 140 babies and mostly term babies, some preterm babies. And with an etiology which is typical for what you see in clinical context. So quite a few of babies with HIE, structural abnormalities, infectious, so sepsis, meningitis, inborn error of metabolism, about a quarter, 13%, genetic and unknown. Our babies had probably a higher proportion of genetic and structural, but this is because all of the people working in the classification task force were in tertiary referral centers. So we have a slightly higher proportion of babies which are transferred for specific problems. But it's a fair representation of the normal etiologies you see in babies. So what we then did was, first of all, we wanted to see whether the classification works. So can we classify those video clips using the new classification? And we found that we could classify all of these babies. Those 10 were excluded because the video quality wasn't good enough. And then we also wanted to see whether whether there's an association of certain seizure types with certain etiologies. So we looked at the seizure types according to the etiology: hypoxic ischemic encephalopathy, vascular, infectious, inborn error of metabolism, genetic, and preterm baby. And what we found is that there was indeed an association. It was an association, so sort of more like some seizure types are more likely. You could also see others, but for example, in hypoxic ischemic encephalopathy, most babies had electrographic only seizures. And that makes sense because babies with hypoxic ischemic encephalopathy are typically critically ill. They are sedated, often muscle relaxed. They're very sick. And these babies typically have electrographic only seizures. The same in preterm babies. So the most likely seizure type in preterm babies is electrographic only, or, as I mentioned earlier, myoclonic seizures. And the same for infectious. So if you have a baby with sepsis or encephalitis, then these are very sick, and the most likely seizure type is electrographic only. In babies, neonates with vascular insults, the most likely seizure type is clonic. I mentioned this also, or electrographic. So again, if the neonate is very sick, critically ill, intubated, and very sick, then electrographic only is more likely, but otherwise they have clonic seizures. And genetic epilepsies, we found you have either tonic seizures or sequential seizures. And again, I mentioned this earlier. So if you have a baby with sequential seizures, then you have to think about channelopathies. Any kind of genetic etiology is very likely to have tonic or sequential. And all of these sequential seizures had a tonic phase. So if you have a baby with tonic seizures, then think genetic. It is very likely that this baby has a genetic etiology, and you can see only HAE, we found a few babies with tonic seizures. Otherwise, none of the other babies had tonic seizures. So there is a clear associations with some seizure types with the etiology. What do you do if you don't have EEG? So obviously, we know that EEG is not available all the time, and definitely not in all centers or in all regions. How do you diagnose seizures if there's no EEG and no AEG? Of course, it happens, and that will affect the diagnostic certainty. So if you don't have EEG or AEG, you need to be aware that there is limited or reduced diagnostic certainty. So what we did was we used a flowchart which was initially created for the Brighton collaboration for the case definition of the Brighton collaboration to define the diagnostic certainties. And we adapted this. This is also in the Epilepsia paper which was published earlier this year. So if you have a baby with high risk for seizures or with clinical events, then if the first question is EEG available, yes or no? If it is available, either continuous EEG or conventional EEG or AEG. If you have conventional EEG with EEG correlate, then this is a gold standard for the diagnosis of seizures. So you have a level 1 diagnostic certainty. If there's no EEG correlate with a certain event, you can exclude that the baby has seizures. If you have only AEG, the diagnostic certainty is slightly reduced, but still you have a level 2 ACE diagnostic certainty, which is definitely enough for clinical management, so a probable diagnosis of seizures. However, if there's no correlate, there's insufficient evidence. So AEG, you cannot exclude that a clinical event is a seizure or not. You can, it's not a seizure. You can only do a positive diagnosis with AEG. If you don't have AEG, then, but the event is observed by experienced personnel, then you can diagnose focal clonic and focal tonic seizures. Here are the two ones you saw earlier. So focal clonic and focal tonic seizures. An experienced healthcare professional can diagnose these, and you can, again, it's a probable diagnosis of seizures. But none of the other seizure types, then it's just a possible diagnosis of seizures, only level 3. And then management becomes very difficult, and you need to think very carefully whether the diagnostic certainty is enough to justify treatment or not. And obviously, if you don't have experienced personnel, then there's insufficient evidence. And finally, classification of epilepsy in the neonatal, with onset in the neonatal period. As I mentioned earlier, most seizures are acute symptomatic and not really the onset of an epilepsy syndrome. However, 10 to 15% of all seizures are the beginning of an epilepsy syndrome. The causes are usually genetic, inborn errors of metabolism, or cortical malformations. Sometimes, not often, but sometimes you have acute symptomatic seizures which do not stop and continue. And then obviously they become an epilepsy syndrome. It's important to remember there is a high comorbidity. So a baby with an epilepsy syndrome, 10 to 30% of babies with an epilepsy syndrome have also another reason to have acute provoked seizures. So for example, if you have a baby with pyridoxine-dependent seizures, that baby might be born with mild or moderate HIE because they're a bit more floppy. And so then initially you might think this is hypoxic ischemic encephalopathy, and later you only make the diagnosis. So that a baby may have 2 reasons or even 3 for epilepsy, and that's important to remember. The International League Against Epilepsy has task force for nosology has very recently proposed 4 position papers, and they were published at the website. So here's the website. There are 4 position papers defining the syndromes, epilepsy syndromes according to age. I mean, so there are a number of there's epilepsy syndromes in neonates and infants in childhood with onset at variable ages, and idiopathic generalized epilepsies. There is the paper with syndromes in neonates and infants is obviously the one which is most important for this talk. And these are the epilepsy syndromes which are with onset in the first 2 years. And the ones which I will talk about are the self-limited familial neonatal epilepsy, self-limited familial neonatal infantile epilepsies. So here and here. Then the early infantile epileptic and developmental encephalopathy, which is one of the severe epilepsy syndromes, epilepsy with infancy with migrating focal seizures, and then some of the etiology-specific syndromes with onset in the neonatal period. So here you see the framework for epilepsies in neonates. So you have the seizure type, which defines the epilepsy syndrome if you take etiology and comorbidity into account. So you need the seizure type, which we discussed earlier. You need the etiology, comorbidity, and then you come to the epilepsy syndrome. And this has been the adapted framework for neonates, which was adapted by from the framework which was published by Ingrid Scheffer in 2017. So I'll go and talk about and present a few of these syndromes which have an onset in the neonatal period. First, self-limited familiar neonatal epilepsy, which used to be called benign familiar neonatal seizures or benign familiar neonatal epilepsy. It also includes what we used to call 5-day fits, or probably most of these babies with the so-called 5-day fits, which are de novo mutations of Casein Q2. So this is a syndrome which has an onset typically on day 2 to 3, and the etiology is a Casein Q2, mutation of the Casein Q2 or Casein Q3, autosomal dominant. Typically, if it's familiar, and if it's non-familiar, it's de novo. The seizure type these babies have is, as I said before, a sequential seizure. Typically, it starts with a tonic phase, then clonic, with autonomic features and automatisms. And the EEG is very helpful here, diagnosing this syndrome. So you have a baby which is well, otherwise, you have a typical seizure type, and you have an EEG which is continuous but often shows multifocal discharges, or even these typical alternating theta bursts. However, in some babies, the interictal EEG is normal. The ictal EEG shows typically an attenuation and then a rhythmic recruitment pattern, which is focal. Exclusionary patterns are if you have persistent slowing, burst suppression pattern, hypsarrhythmia, or a lack of correlate, then you should not diagnose self-limited familiar neonatal epilepsy. Next is early infantile epileptic and developmental encephalopathy. Also, what I forgot to mention is the baby I showed with the sequential seizure was a baby with Casein Q2. So that's a typical sequential seizure. Next syndrome is the early infantile epileptic and developmental encephalopathy, which we used to call, basically this is the combination of Otohara Syndrome and early myoclonic encephalopathy. So previously we had early infantile epileptic encephalopathy or Otohara Syndrome and early myoclonic encephalopathy. And the task force decided that there are so many overlaps and similar etiologies between the two syndromes that it would make sense to combine them into one syndrome. So now we have early infantile epileptic and developmental encephalopathy. So the Otohara syndrome used to be lesional or genetic. The primary seizure type was tonic or tonic spasms. They also had focal seizures. The EEG pattern was burst suppression pattern, and the outcome was very poor, with many of them going into West syndrome with hypsarrhythmia. And early myoclonic encephalopathy is typically metabolic or genetic, had myoclonic seizures, but also focal seizures or spasms. And again, the EEG was typically a burst suppression pattern, and the outcome was poor, with a high morbidity and others going into West syndrome. So because of these, you can see here genetic, focal seizures, burst suppression pattern, and very poor outcome. This is why these two syndromes were combined. So we have an onset of seizures mostly in the neonatal period, up to 2 months. Most of these start within the first 2 weeks. The etiologies are variable, can be lesional, metabolic, or genetic, and seizure types are either tonic, myoclonic, spasms, or focal seizures. So here's a baby with an inborn error of metabolisms and spasms. And in the EEG, you can see the typical burst suppression pattern. So the EEG often shows burst suppression pattern, but in some it may be discontinuous with an encephalopathy, but it's always abnormal. And ictal pattern obviously depends on the seizure type. So mandatory, you have either burst suppression or multifocal discharges and diffuse slowing. And the EEG is characterized by an encephalopathy. Now here's an example. This is the baby with the focal seizures, which I showed you earlier, was born after an uneventful pregnancy, normal initial neonatal period, and then the onset of asymmetric tonic seizures. Yeah. So later, the baby, she also developed tonic spasms. They didn't respond to medication. Her MRI was normal, and this is her EEG. So she has a burst suppression pattern and an ictal tonic seizures, and her genetic panel showed a de novo mutation of the STXBP1 gene. And another baby, this video here is a very old, it's a historical video from Perrine Pluon, and you can see the facial grimacing and then spasms. So the combination of a really stressed baby with facial grimacing and spasms is typical for paradox-independent seizures, early onset seizures, which are typically myoclonic or spasms. And the EEG shows a burst suppression pattern, which can be ictal. So if you look here, you see a burst suppression pattern, and with each of the bursts, you can see that the baby has a myoclonic seizure, or here even a spasm. So in paradox-independent seizures, typically the burst suppression pattern is an ictal pattern, not an interictal pattern like in other babies. And then the baby also has focal seizures. Other features are status epilepticus, non-specific slowing, and multifocal discharges in the EEG. Important is to remember, if you have a baby with paradox-independent seizures and you give pyridoxine IV, so here is another baby, very similar EEG as to the one I showed you earlier. Again, you have with each of these bursts, you have a seizure, and then the baby was treated with pyridoxine IV. And what happened is that the EEG became completely flat, which proves that, so all these seizures stopped, the baby was in status, and then no more seizures. But together with the suppression of the EEG, the baby also had a respiratory arrest. So if you give pyridoxine IV to a baby with paradox-independent seizures, they can't stop breathing. So you need to be aware of this and be able to resuscitate. The EEG activity comes back and the baby starts breathing again, but that may take up to 24 hours. So you may need to ventilate this child, this neonate, for a while. And then finally, epilepsy of infancy with migrating focal seizures. The onset is usually in the first 6 months of life. They are genetic seizure. It's a genetic epilepsy syndrome with focal motor seizures, which increase in frequency, and they migrate from one side to another. So here you have an EEG, 4 right, 4 left, and you can see that the onset of the seizure is over the left, and then it migrates to the right. So mandatory is an ictal migrating pattern and multifocal discharges. Burst suppression pattern is not typical for these babies. So again, here's another example of a baby with a seizure onset over the left, and then it migrates slowly over to the right. There are different genetic mutations which can cause this syndrome. And finally, 2 examples of babies with etiology-specific syndromes. One is Casein Q2 Encephalopathy. So again, a sequential seizure. This starts in the middle of the seizure, and you can see that the baby has a tonic phase with automatisms, and later a clonic phase. So this is a de novo mutation of Casein Q2 with sequential seizures. And here's the other baby, which I showed you earlier. So here you have a baby, you have the alternating theta bursts, which I mentioned earlier in the interictal EEG. And the ictal EEG, so first there's a suppression here with the seizure onset, is a suppression, and then a focal ictal recruiting pattern. And at the end, you have a burst suppression pattern. So because there's a prolonged period of burst suppression, this is Casein Q2 encephalopathy rather than a benign course or benign epilepsy syndrome. And as another baby with a channelopathy, SCN2A encephalopathy. So here is a baby with, again, a sequential seizure with tonic posturing. First the left arm, then the right arm, and again, oral automatisms. And then he turns to the other side, and again, you can see the automatisms at the end. So this baby had a de novo SCN2A mutation with sequential seizures who responded very well to carbamazepine. The interictal EEG is initially normal, but later can show burst suppression pattern or multifocal discharges. So here you see the interictal EEG of this baby with multifocal discharges, and then the ictal pattern is with an onset over the left, and then the seizure migrates to the right and is more sustained over the right. And you can also see that there is a post-ictal burst suppression pattern, which is typical for these encephalopathies. So in summary, the EEG should really be part of any neonatal seizure classification, and is for the new classification I presented. If there's no availability of EEG or AEG, that affects the diagnostic certainty and has to be taken into account when managing those babies. Some seizure types are indicative of certain etiologies. And overall, the semiology of neonatal seizures can aid the diagnosis and consequently the management of the treatment. And the same is true for the new proposal of epilepsy syndromes in the neonatal period, which you can find on the ILE website. And I'll end with my acknowledgements. Thank you very much.